Okay. Good morning, sir. Good morning, everyone. So, we all know that since the time man has learned to critically argumenting for something, a debate has always been regarded as a hallmark of human intellect. In almost all the debate, what we see is at the end of the debate, we come to some conclusion, except in one never-ending debate on man and a happy life. So married life. So coming to the scenario under my debate is, what is presumed is the other eye is absolutely normal in unilateral cataract, and a refractive lens exchange or presbyopic phakic IOL is not under consideration of neither the surgeon nor the patient. So if you look at the etiology of unilateral cataract, the congenital syndrome and the pediatric age group are the most commonly seen in the patients. And in younger adult or the adult, the trauma is the commonest entity. But the reason is not known, but a significant proportion of the idiopathic patients where we are seeing the idiopathic reason for the unilateral cataract is also very common. So these are the subsets of patients where I will try to convince why I will go for monofocal rather than multifocal or trifocal lenses one by one. So what is the essential criteria for giving a patient trifocal or multifocal? We do not want to see any surprise in the residual refraction or the resting residual refraction when we have implanted the trifocal lenses. So in pediatric population, what is most challenging is getting biometric, right biometry, because the eye is weird, and there are some of the biometric surprise are there, and we do not have consensus over how the eye will behave even after the surgery. So after the surgery, even if you have implanted the lens, there is a changes in the shift in the refraction of the patient's eye. So if you will implant multifocal or trifocal, and there will be residual, the refraction error, then the condition will be more devastating. So this is the subset of the patient where in unilateral cataract, definitely I'll go for monofocal lenses. Coming to the traumatic cataract, we all know that assessment in trauma is difficult and challenging because the impact of the trauma in traumatic eye is lot of, there are 7 rings of trauma in the basics we used to read. So starting from cornea to sphincter tear, which will lead to permanent, mid-dilated pupil, and the trauma in the canalicular system, which will later on give rise to glaucoma, and subtle injury to the retina, parafoveal region will lead to lessened contrast. So these are the another subset of the patient where I will consider a lot before implanting multifocal, and it would be safer to give monofocal if the patient is having unilateral cataract, because the other eye is absolutely normal and patient will keep comparing with the other eye. So my take here also will be monofocal against multifocal. The most challenging debate is if the patient does not have any such kind of difficulty, and why I will choose monofocal rather than multifocal is based on the psychological status definitely of the patient. If we see that the patient is of that type A personality and there is a chance that patient will keep on comparing after the surgery. Since the other eye is absolutely normal, and we know that whatever be the technology, multifocal is going to have some of the negative effects in terms of reduction of contrast and halos and glare. So if I believe that the patient is that category of psychological profile wherein he'll keep on comparing his vision or the profile with the other eye, then I'll think over giving monofocal rather than multifocal. So to conclude, I'll say that case assessment is very, very important. Rather than just jumping to multifocal in every cases is not a good idea. Long-term implication of the case and judiciously implanting the lens is very important. We should choose the best for that particular scenario, and of course it should be justified by science.